Hi, I'm Danica Koopmans.
And I'm Sharon Hughes-Geeky. We're your hosts of Docs of Vernon. This is an interview and podcast series designed to help you navigate the healthcare system and get to know the physicians that provide your care.
Topics include what the heck is a hospitalist, treating addictions, and alternatives to going to the ER, plus so many more.
This is your link to healthcare in your community.
Hello and welcome back. I am so excited today. I have Dr. Hardy with us, and he is a BC cancer medical oncologist. He has so much just knowledge and passion for this profession. Always enjoy our time together and talking. So today we bring him here to answer many of our cancer-related questions. And we've discussed that we're going to try not to laugh too hard because
this is serious, yes.
It's very serious. So he has had a deep dedication to patient care here in Vernon over 20 years?
25 now.
What was it like before you had come here?
Well, Vernon had a cancer center for years with Tom McMurtry and Peter Baer, and that's who the cancer center is named after. And then they passed away, and there was a community initiative to actually sort of build a separate unit within the hospital, which had been here. There was another oncologist here for about a year or so, and then he left. And so I was recruited here as a bit of an experiment, actually, to be a BC cancer medical oncologist in a community setting, because up until that, there's been sort of a split of BC cancer oncologists are usually in the regional centers, and then there are some community oncologists, so I have kind of a foot in both camps. There's more of us now. So,
yeah. How many are there?
Well, there are 3 of us here in Vernon. We're hoping to recruit a 4th later on this year. The Kamloops group is similar. There are sort of BC Cancer satellite clinics, without medical oncologists, but with BC Cancer staff in places like Nelson and Trail and Cranbrook,
okay,
and Penticton.
And do you ever travel to those areas, or do you stay strictly in Vernon?
We're busy.
Yeah.
I helped out several years ago in Kamloops when one of the oncologists there was sick, but that was probably 15 years ago now, I think. I don't know, time flies. We just kind of stay in our clinic here because we're just busy. So.
And I know one of your passions is in hematology.
Mm-hmm.
So what does that actually mean from a cancer standpoint?
Hematology is blood.
Yes.
So there's benign hematology, like why is somebody anemic? Why is their white count too high, whatever. But I deal with the malignant or cancerous hematology, so that's basically Hodgkin's lymphoma, all the other lymphomas which are not Hodgkin's, so the non-Hodgkin's lymphomas, multiple myeloma, some leukemias.
Wow.
So that's what I really like. But I also see people with breast cancer and colon cancer, and I'm not seeing so much lung anymore because we have some more help here. So, and then mostly the GI tract ones like stomach, esophagus, colon, liver, that sort of thing.
Why do you find working with cancer patients rewarding?
Oh, I like people.
Yes.
Medicine is a people profession. When I was doing my residency, I actually wanted to do obstetrics when I was an intern.
I can see that.
But I realized there were only 2 ways to practice it, because both were there in Saskatoon where I did my training. There was the big group of, 8 or 9 obstetricians, and they shared call. And then there was the solo guy. And the people who were in the big practice had a better life, because they weren't on call every night. But the thing about obstetrics is the whole purpose of seeing people is you want to get them to a healthy baby.
Right.
And so then you'd only have a 1 in 7 chance of actually delivering that baby if the lady delivered at night, which of course it seems like everybody does. Right? So I decided that I wasn't going to do obstetrics, and I did internal medicine, but I really liked hematology, which is really what I set out to do, and ended up in an oncology program as well. You really get to know people in oncology. Like, say, emergency medicine, you see people, they come and go. General surgery, the same. It's sort of, you operate on somebody's gallbladder or whatever, and then may not see them again. But with oncology, people come in with their families, you get their story. Everybody has a story.
Yes.
You get to know them. And you sort of help people understand the cancer that they have and what the treatment options are. And obviously a good number of people aren't curable, so you're with them sort of for that journey, until they pass away. And you really get to know people. You get a real connection. I mean, it's not that it isn't hard, because I mean, everybody in medicine has some degree of PTSD.
Yeah, absolutely.
It's inevitable. There's some patients that you really feel like you lose a little piece of yourself if they pass away, but we have a lot of people too that come in with bad cancers, and we cure them, and then you're seeing them 5 years later, 6 years later. And this is a small enough community. You run into people socially as well, and I'll run into kids and spouses of people I looked after 15 years ago, and I find it very rewarding. It's kind of fun, actually, which is okay. It's a weird thing to say, but I enjoy it.
Yeah, absolutely.
It's a real continuity.
But that's invaluable when it comes to patient care, especially in such a difficult journey that somebody's going through, to be able to have that perspective, and to bring some of that fun. Like, truly, the humor and the laughter that you bring to life is exceptional.
I think people are maybe surprised when they come into the cancer center that it's like we have fun. The great group of nurses and the other doctors I work with and clerical staff, there's usually some laughter going on somewhere.
Healing medicine.
It is. There's nothing more therapeutic than a good belly laugh.
So shifting gears, we'll give you guys some knowledge here. Dr. Hardy actually brought some awesome little screen prompts for us. So he took this seriously.
Literally screen prompts, because when people come to see me, they've been diagnosed with cancer. So lung cancer, for instance, the commonest cancer in women are breast, lung, colon. In men, it's prostate, lung, colon. The biggest killer is lung. And so, there are screening programs to help people perhaps get diagnosed sooner. There are barriers to screening. I mean, some people don't want to screen, but as you know, we have a shortage of primary care people, which can make it challenging to get screened. But I'm here to talk about that. So I'm going to say, get screened.
Love that.
So some information. So for breast cancer screening, everybody knows about the mammography programs. You can screen. The age has recently shifted down to 40. I know there was a lot in the news about whether it should be 50 or 40. We see a lot of people in their 40s. So if you're over 40, get a mammogram. You can self-refer with that number and get a screening mammogram. Or you can talk to, obviously, your primary care physician. There's also some clinics in town, because you do have to have a name attached to the requisition. And so, there's a Vernon Women's Sexual Health Clinic that you can see. There's walk-in clinics. There's also these online, like My TELUS Health, Rocket Doctor. There's cancerscreening.ca that you can go in and answer questions, and they will do a sort of a remote consultation briefly, and then they will get you linked up with mammography. So if you don't have a lump already and you don't have symptoms, then get a screening mammogram. If you have implants, that is an automatic diagnostic, because it takes longer, and so that you can't really self-refer for that. You'd have to get referred for one of those. And then this one is colon screening, and March is Colon Cancer Awareness Month.
He really didn't want to show his face, so that's why he's
I'm just going to hide behind here. And so that one is what's called a fecal immunohistochemistry, or FIT test. I guess it'd actually be FI, because the T is test, so that'd be a FIT test.
Yes.
But so what it looks for is microscopic amounts of blood in the stool. The gold standard is a colonoscopy, but there's just no way that we have enough scopers or time to scope everybody in the population, so we do the screening test. Again, you need a requisition, so you have to have, you go to your family doctor if you're in the age group that I've listed there, and you get your requisition for the FIT test, and you go to Life Labs or whatever, pick up the kit, send it in, and then if there is something abnormal, then you will be contacted for a colonoscopy to put a scope up and take a look. If you're actually having symptoms, the number of people I see with colon cancer who'd had some bleeding and a bit of change in bowel habits, and they kind of ignored it for months because they said, oh, it's probably just hemorrhoids or something. But if there's something going on, then go to your doctor about it, because it's way better to catch these things early if possible. If you don't have a family doctor, then you can, go to the walk-in clinic or urgent primary care or whatever. Basically, if you are between 55 and 74 and you've smoked for 20 years, now that doesn't matter if you're doing it now or you did it but when you were like 20 to 40, you're eligible for screening. Most lung cancers are caught late because usually lung cancers are caught when they're causing some sort of symptom, like you're coughing up blood or you're short of breath or whatever. And by then, usually you've got a big tumor because it's big enough, it's affecting the airways. And often by then, it's too late, which is why lung cancer is the number one cause of cancer death. So we would rather catch these things when they're little nodules or, 1 centimeter, what is that, and take it out. So it's a low-dose screening CT. There is a BC Cancer number there you can call that they'll go through the eligibility and they'll set it up. And then you'll get your CT scan and will be notified if there's abnormalities that need to be dealt with. And then last but definitely not least, I think Dr. Half in his interview, which I know you all watched because it's already posted, may have talked about cervical cancer screening, but there's a bit more detail here. Cervical cancer is pretty much 100% related to HPV. It's a viral cancer. And so you used to have to go for the Pap test, which of course nobody ever liked because the speculum is cold and it's uncomfortable, and it's also a technical test. You have to actually be able to visualize the cervix, so sometimes we get results back that said this was an inadequate sample or whatever. The new system is much better. It is simply a vaginal swab that the person can do themselves, and it looks for the human papillomavirus, the HPV. So if you don't have it, then you won't have cervical cancer, so you don't need further investigation. If you do have evidence of the viral infection, then the system will automatically contact you and send you to someone like Dr. Half for a colposcopy where they go in and take a look at the cervix. So it is it's something that people can order themselves. I do believe it still does require a doctor's name on it, but again, you can go to one of those other websites I talked about, or the Vernon Women's Sexual Health Clinic, or walk-in clinic, or your family doctor, and it'll get set up. But it's pretty automatic, and it's really nice because people can do it at home.
Yeah, absolutely.
So these are all important things. I mean, there's all the usual things about cancer prevention, like eating healthy, which is important not just for cancer, but for cardiovascular health, general fitness, staying active, don't smoke. And don't smoke cannabis either. Like, nothing should be set on fire and put in your mouth. Like, just put it that
the way he says
way.
it.